To our next series on diagnostic imaging for the athletic trainer. Again, I'm Dr. Max Cohen, and today we're going to review some of the most common forms of imaging modalities and try to focus on some of the more relevant applications to athletic training. We'll start with the X-rays, or what's called the plane radiograph, invented originally in 1895 in Germany by an engineer, Wilhelm Röntgen. And I understand that the X in X-ray originally meant that it was sort of an unknown ray, which we later determined was accelerated electrons. And essentially, when these electrons are fired at an object, some of it gets absorbed and some of it passes through. And so the more dense tissue, like a bone, tends to absorb it, and the less dense tissue, like soft tissue, tends to transmit straight through, and you end up with the images that we know as an X-ray. And these are really helpful for looking at bony tissue, specifically for things like fractures, to look for dislocations when a bone is out of position, to look for alignment after a surgical procedure, and different forms of bone-specific diseases like bone tumors or Paget's disease or lytic lesions of certain diseases where there's actually sort of a cutout appearance in the bone. Here's a couple of examples. This is what's known as a boxer's fracture, which is a fracture of that fifth metacarpal, typically from punching something hard with a force transmitted through that metacarpal head. Dislocations here, which tend to be pretty prominent, as you can see in that image on the left there of the middle and distal phalanx, significantly malaligned. And then in this elbow image here, you can see large fracture through the distal humerus there. And in the distal phalanx, looking at some discontinuity in the smooth bony margins, which we'll review more in class, sort of how to methodically go through an image like this and be able to look for abnormalities. And this brings us to the CT, or computed tomography scan, invented in 1972. And essentially the X-ray tube and detector are rotated around the body part being examined, and this creates a 3D image with several thin slices that you can then sort of reconstruct a 3D image virtually of. And this is really good for looking at bony tissue, but with a lot more detail than a standard X-ray, which helps to look at bone in a way that helps to elucidate maybe a more subtle stress fracture or early infection or something like that may not be as easily visualized on an X-ray. And a drawback here would be that the soft tissue is often not as detailed as it would be in an MRI image. There's also quite a bit of radiation exposure with this, which we'll talk about in just a moment. Here's some images of a head. The white circumferential component being the bony part of the cranium, and then the darker color in the middle there being the brain tissue, and the black being sort of the fluid components of the brain there. Here's a 3D reconstruction of what looks like some bronchus and bronchioles on the left, and then the vertebrae of the spine on the right. And you can see here how a complicated fracture of the spine, as you can scroll through several different cuts, you might not catch the fracture on just one cut, but then as you continue through the cuts, you can see that there's actually several fractures and some degree of comminution, whereas that X-ray image on the left doesn't really provide nearly as much detail. And this is a great slide for counseling patients on relative radiation equivalent dosage. So radiation is measured in what's called a millisievert, and that is significantly more in a CT scan than an X-ray typically. And in a typical day, you are exposed to a certain amount of background radiation just from the environment that you live in. Bananas actually have a small amount of radioactivity. Cosmic rays coming from space, a lot of sources of a very small amount of radiation that we're exposed to every day. And a single chest X-ray is about the same amount as 10 days of that background exposure to radiation. A mammogram is equivalent to probably about 7 weeks of natural background exposure. And then you can see on the left side, a dental X-ray is like 0.1 or 2 millisieverts. It's a very, very small amount of radiation comparatively to a lumbar spine X-ray, which is a bit more, a barium enema, which is quite a bit more. And then on the right column, they're looking at the CTs. An abdominal CT is 5 to 7 millisieverts. A abdomen and pelvis, 8 to 14. And when you are looking at the coronary blood vessels with a dye study called the angiography that we'll talk about later, that can get up to 5, 10, 15 millisieverts, with a PET scan being about 25 millisieverts, about 8 years of average background radiation exposure. And so just so you have an idea of the relative degree of radiation that some of these studies might have if your patients are particularly worried about the risks and benefits of exposure to radiation, to gather some diagnostic data. And that brings us to the MRI, or the magnetic resonance image. And this was invented in the 1940s, but then sort of developed a medical application much later into the 70s or 80s. As you might know, the human body is made up of mostly water and fat, and the modality works basically by having a very large, powerful magnet that alternates its alignment on and off. And what that does is sort of produces a current by exciting the protons in the body tissues. And then as those protons come down into the relaxed state, they give off energy, which the MRI detector is able to pick up. And so MRI is very good at detecting detail in soft tissue, which is largely made of water and fat, etc. And it tends to be not as ideal for bony visualization, but it actually is fairly good at looking at bone marrow and does have some bone applications. The major benefit here, besides being great for soft tissue, is that it doesn't have a radiation exposure, which is great for young people, babies, folks who, when you're trying to avoid radiation exposure. And essentially, the patient is on a sort of table and then gets passed into this circumferential sort of donut, and with the detector, rotating 360 degrees around the patient. And here's some example imaging. The knee on the right there, you can see there's a fair amount of detail in the bone, and then you can see a really nice black triangle representing the medial meniscus, and you can see some of the thicker tissues between the tibia and the femur representing the medial collateral ligament and the lateral collateral ligament, which are labeled there. And we'll review a bit more in class about how to interpret some of these. And on the right there, that thick black line from the anterior tibia to the posterior femur, representing the anterior cruciate ligament. And you can see how there's a fair amount of detail there, and if there was a discontinuity in that solid black line, you might be concerned about things like an ACL tear or whatever ligament it may be demonstrating. You can see X-ray on the left side there with very poor soft tissue visualization, but nice example of the bony outlines. And then on the right there, doing a much better job of the soft tissue visualization, seeing the fat pad at the heel there and a lot of the muscular structures, in addition to some of the bones on the right. Here's a spine image that shows the spinal cord in the white, just inside the spinal column there, with the vertebrae stacked on each other with discs in between each. And you can see in this particular image there's a protrusion of the disc or herniation at the lower lumbar vertebrae there, with a color sort of reconstruction on the right there for to sort of help orient you. That brings us to the MR arthrogram, or magnetic resonance arthrogram, and the key here is that you're including contrast dye. And in an arthrogram, the contrast dye is injected into the joint that you're interested in evaluating, and that helps elucidate tears in tissue like cartilage or muscle or tendon that sometimes is hard to see with an MRI. So it can help increase your sensitivity for picking up some of these subtle tears. And in this picture on the right there, you can see a tear through the glenoid there at the labrum. And then heading over to the rotator cuff, on here you can see fluid sort of leaking out with some fraying in the rotator cuff tendons. And then a MR arteriogram or angiography is a similar idea of using contrast dye, but injecting it into the blood vessels to help better visualize the blood vessels as opposed to a joint, which we saw in the arthrogram. This is helpful for looking for blockages or blood clots, aneurysms, anything that requires you to visualize the blood vessels better. And on the right, you can see the blood vessels in the brain that would be presumably looking for evidence of stroke or narrowing or potentially aneurysm. And then we have the bone scan, which uses a radioactive isotope that is specific for bone, and it gets injected into the bloodstream, circulates around, and then gets collected into the bones, and it will particularly accumulate in areas that have a high metabolism. And so fractures, cancer, infection, these are processes where the cells are functioning at a higher metabolic rate. And so on a bone scan, these areas will sort of light up a lot more. And then you can additionally use X-ray or CT to look at those areas in specific. In the image on the top there, you see the sort of those black areas where there's increased uptake of this radio tracer, and that would be consistent with potential stress fracture in the calcaneal bones. And then on the bottom there, that fourth metatarsal on the left with increased uptake might indicate a stress fracture in the right clinical setting. It's often used in evaluation of osteomyelitis, which is a infection of the bone, often used in evaluation of stress injuries like a stress fracture, um, and sometimes in folks who are being evaluated for cancer when there's concern for metastatic spread to the bone, and sometimes if people are having continued bony related pain and you have done other advanced imaging and it's been unremarkable, you might use a bone scan as another alternative modality. It is particularly sensitive in early processes of, for example, infection or stress fracture, that oftentimes the x-ray will miss, and maybe less often the CT will miss, but the bone scan will pick up. And MRIs are also fairly good at seeing these early findings of maybe increased edema and fluid and inflammation in a bony area. However, MRI tends to be much more expensive, which I'll talk about shortly, just relative cost of some of these things. And it also may be availability in your local hospital system, or what your particular specialists and physicians choose to order for just their comfort and protocols for different injury evaluation. For ultrasound, it was often used as a treatment in the early 1900s and then started to have more diagnostic applications into the 1940s, and then in more recent times has developed application in the orthopedic setting, particularly now in 2023, as we are having more access to point of care ultrasound with portable ultrasound units. And it's essentially taking electric current from a wall power source and vibrating a small crystal in the ultrasound to create what's known as a piezoelectric current. And that makes sound waves. And when you get those sound waves, they hit tissue and they bounce back to the ultrasound and produce an image, sort of like how a bat would use sonar. And you may have heard of this, frequently used to look at a developing fetus in a pregnancy. But now we're finding much more application for looking at tendons to see if there's any tearing or tendinitis, looking at blood flow, heart function, like an echocardiogram, which uses ultrasound technology, and then even looking at internal organs for signs of bleeding, to look for fluid backup, to look for collections of infection, and several other applications. And one of the really big advantages here is that there's no radiation risk to the patient. And as these tools and this technology becomes more accessible and affordable, it tends to be much more applicable at the point of care. And the provider, the physician, PA, the athletic trainer, physical therapist, etc., may have a lot more access to this in the coming years. And I think you'll see a lot more musculoskeletal professionals developing a real skill set with point of care ultrasound. Here is an example of an ultrasound image, and you can see a fetus in a uterus there on the left. Here is a supraspinatus tendon on the left. You can see some nice linear, continuous, sharp white sort of lines, and then on the right there you can see it's a lot less continuous and linear, a lot more sort of boggy and edematous looking. And we'll review in class more of the language and terminology that we use to describe these things and some of the basic skills of point of care ultrasound. That brings us to fluoroscopy, which you can sort of think about as X-rays in motion, sort of so dynamic X-ray style pictures that are often used during procedures like an injection, a surgery, or at the point of care after um, a reduction of a dislocated bone or fractured bone. And the perk here, or the benefit, is the live video images that you can produce. And so it is using radiation, and it's using it in sort of small bursts to create moving pictures, several pictures that you can see. For example, if you inject a dye or you are inserting a needle into an area, you can actually follow that needle tip into the joint of interest. Or if you have a fracture that you just put a pin in and you want to see if it looks straight, you can do that right on at the point of care. And this can be really helpful in places like the operating room or in like a football stadium, because you might not have a formal X-ray machine available, but you might have access to fluoroscopy. And here's an example of some of the images that are created. You can see on the image on the left, the right portion, that there is a fracture to the base of the fifth metatarsal. And then you can see the fluoroscopic image on the left side of that, showing a pin that was inserted to assist with the healing of that fracture. And on that right side, you can see a cervical spine where they likely were doing a injection into the epidural space. So in summary, you have X-rays that are great for the initial evaluation of bony injuries like fractures and dislocations. Tend to be more affordable and easy to access. Then you have CT, or computed tomography, that will give you a more three-dimensional, better detailed view of bony tissues predominantly, but more expensive and more radiation. Then you have the MRI, which is going to tend to produce the best images for soft tissue, no radiation, fairly expensive and sometimes hard to obtain, and also sort of takes quite a bit of time to get the image during the scan. Then you have the MR arthrogram, where you inject dye into the joint to help emphasize things like tears. Then you have the MR angiogram, where you inject dye into a vessel to help look for clot or narrowing. In the bone scan, you are getting areas of concern and sort of a general perspective of these areas of hyper or elevated metabolism, but you're not really getting other details about the tissue in that area, the bones or the soft tissue. In the ultrasound, you're getting typically a nice, easy point of care test, potentially with no radiation, and has a lot of good applications for several different body parts, gaining increased utilization in orthopedics. And then fluoroscopy, which gives you that real-time series of pictures, good for bony tissue, particularly for procedures and getting a sort of a quick look at fractures and alignment. Some pearls and pitfalls here. Keep in mind that imaging can take up a lot of time and money, and never underestimate the value of a good history and physical exam, which can often be more clinically important than the imaging findings. Sometimes you might find a, quote, positive finding, but it doesn't necessarily mean that that is the cause of the patient's pain, and that there may be a different justification. There is also a terminology called incidentaloma, and this is the idea that you might be going looking for one thing and you find something completely unrelated that you didn't even expect to be there, for example. if you do a CT scan of somebody's belly looking for a reason for their right upper quadrant pain, and you find that there is a adrenal mass on the left side, and it's not causing them any symptoms, and you wouldn't have had any idea that it was there otherwise, and now you sort of have to figure out what to do with this imaging finding. And so those are called incidental omas, meaning an incidental finding. And then keep in mind that some findings on imaging that appear abnormal are actually normal, or even if they are abnormal, they may not change your management, the fact that you know about them, that the process might still be to do, structured rehabilitation protocol, rest, ice elevation, etc., and continue with conservative management. So that imaging study may not have provided you any additional benefit to the patient. Some findings that we find, as I mentioned, are unrelated to the complaint and can lead to unnecessary interventions, increased morbidity and even mortality. For example, if you find a rotator cuff tear that was not actually the presenting complaint or related to the patient's complaints, they end up going to surgery, and then they have a worse outcome after that, or they die in surgery, or have some other terrible outcome. And so we do want to try to protect patients from unnecessary interventions like that. And then I'll also mention that oftentimes patients and providers alike can fixate on particular imaging findings, in the sense that, for example, I had a patient who had x-rays that showed sort of a mild to moderate scoliosis, and then he sort of fixated that his back pain was always due to this scoliosis, and that it was not a reason why he was not going to get better. And so patients who fixate on a particular diagnosis, or even providers who fixate on a particular diagnosis, may not be as willing after seeing imaging findings to accept a different explanation and a different reality. Here's just a quick sort of summary of some specific parts of the body where we can note some of these correlations. In the neck, physical exam and pain patterns do a fairly good job at predicting cervical herniation, and then you can see that the MRI will increase the predictive ability quite a bit. And then a CT myelogram, where you're doing CT imaging with dye injected into the space around the spinal cord, that gets you even more predictive capability. In the shoulder, a lot of what we can do for a physical exam tends to be very sensitive, but unfortunately not very specific. And so MRI is a great way to improve your specificity for identifying tissues that are causing symptoms, including rotator cuff tears, for example. And in the wrist, you can see that evaluation for carpal tunnel, for lumbar. You can see evaluation for acute back pain, and then in the knee there, often not a huge difference between MRI and clinical exam for some common knee injuries. Here is a look at the cost versus the value. Keep in mind that office visits already are fairly expensive, going to the doctor. But then take a look here at how an x-ray might only be a couple $100, whereas an MRI, typically a few $1,000s. EMG, or electromyography, looking at nerve function, can be a couple $1,000s. And then CT and PET scans also in several $1,000s. And then there's often a radiologist fee and sometimes a facility fee for wherever you go to get this imaging done. And so these are all just important things to keep in mind when doing good patient-centered care. So keep in mind that your physical exam is very important, and then your imaging becomes more important when your physical exam is not giving you the right information that you need. If they're not getting better as you might expect, if there are significant red flags on the physical exam that would indicate that this is a really severe disease process with a potentially poor prognosis or other confounding conditions, then you might be quicker to use some imaging study. And with the idea being that a delay of diagnosis could contribute to disability, such as a tumor, in the spinal cord, causing neurologic dysfunction, and making sure that you're working that up immediately to try to reduce morbidity and potentially mortality. Some questions to ask yourself when you're ordering the imaging. What are you imaging? What are you looking for? How acute is it? Did this just happen, or has this injury been more chronic? What's on your differential? What could happen if you're wrong? And could the imaging cause other problems? Can you create more of a headache from doing the imaging than you would from holding off on the imaging and maybe putting it in your back pocket? With the goals here, as we said, of trying to save some money, trying to save some time, trying to not expose patients to increased radiation, reduce the amount of follow-up needed, so that they can live their lives, and try to save patients from inappropriate intervention, and also maybe reduce opportunities for inappropriate litigation. And when we see y'all next week, we'll go ahead and dive into some practice cases, and we'll try to focus on X-ray, MRI, and ultrasound, which will typically be some of the most common studies that you'll see in athletic training. And I look forward to seeing you all then.